Thank you for joining us today to talk about breakthroughs in treating non-small cell lung cancer, targeting KRAS. My name is Dr. Christine Bestvina. I'm an associate professor at the University of Chicago in Chicago, Illinois. Today, we're going to talk about the treatment landscape for RAS-mutated non-small cell lung cancer, which is undergoing transformative changes with advances in targeted therapies, biomarker-driven combinations, and evolving resistance management strategies. In the next three presentations, we'll examine the molecular mechanisms of KRAS mutations in non-small cell lung cancer, as well as take a deep dive into the clinical efficacy and safety data of KRAS inhibitors. Let's start by reviewing the significance of KRAS mutations in non-small cell lung cancer. So why are RAS mutations important in non-small cell lung cancer? We'll look at the role of RAS in oncogenesis. We'll look at common KRAS mutations in non-small cell lung cancer, as well as their significance. And we'll discuss testing strategies for KRAS mutations, as well as current challenges. The RAS family, including KRAS, NRAS, and HRAS, are small monomeric G proteins. When they're bound to the GDP form, or guanosine diphosphate, they're in the inactive form. However, when bound to GTP, or guanosine triphosphate, they're in the active form. When GTP binds, this changes the conformation of RAS at switch 1 and switch 2 regions, enabling it to bind to its effectors. So what does this look like in the cell? External cellular signaling, such as cytokines, hormones, protein kinases, transcription factors, and others, will activate kinase activity, leading to intracellularly the GTP-bound form, or the active form. This can trigger downstream signaling pathways such as RAF, which lead to cell growth and survival. Looking across the RAS family, we see KRAS, NRAS, and HRAS all encode isoforms that are highly conserved sequences with structural homology across the three. You'll see that the primary mutational hotspots are located at G12, G13, and Q61 in all three RAS isoforms. These comprise the intrinsic GTPase activity of RAS. So what is the role of RAS in oncogenesis? Mutations in KRAS, particularly at codons 12, 13, and 61, will result in a persistently active GTP-bound state. This leads to continuous activation of the signaling pathways downstream. This dysregulated signaling is a common driver of oncogenesis, leading to uncontrolled cell growth and tumor development. These KRAS mutations are particularly common in pancreatic cancers, as much as 59%, colorectal cancers, 36%, and 27% of lung adenocarcinoma. What are the specific KRAS mutations that we see in lung adenocarcinoma? Of those 27%, you'll see KRAS G12 mutations account for almost 85% of KRAS mutations in lung adenocarcinoma. KRAS G12C is the most common at 40%. This is followed by G12V at 19% and G12D at 15%. Let's look now at some of the co-mutations that occur in non-small cell lung cancer. For patients who are KRAS wild type, the most common co-mutation is TP53 at 74%. However, for those who are G12C mutated, TP53 predominance decreases to 49%, and here we see an increase in STK11 and KEAP1. These co-mutations can influence the biology and immune microenvironment of the tumor and are increasingly being recognized as prognostic biomarkers. So how do we test for these important mutations? Well, we know KRAS is a therapeutically relevant biomarker. Therefore, ESMO and NCCN recommend testing for KRAS G12C mutations. NGS panels are the best recommended approach for detection. Most of these also will now detect STK11, KEAP1, and TP53 co-mutations. However, one problem that we see in lung cancer is adequate tissue material for histologic diagnosis. We have such small tissue amounts in lung cancer, oftentimes because of bronchoscopic diagnoses, that there may not be enough tissue to perform molecular analysis. In these cases, cell-free DNA or liquid biopsy can be used as a complement if there is insufficient material or if turnaround time is an issue. Reflex testing is preferred to try to shorten these turnaround times so that we can get patients on treatment faster with the required information. What do we know about the prognosis of KRAS-mutant non-small cell lung cancer? Well, detectable cell-free DNA can be linked to worse outcomes. This is common across many cell-free DNA platforms for many different mutational types. We know that KEAP1 and STK11 co-mutations can have a worse prognosis, as well as SMARCA4 co-mutation. How does this affect treatment efficacy? Well, we know that having a co-mutation with KEAP1 or STK11 may lead to worse outcomes with single-agent immunotherapy. And there's emerging data that perhaps these patients may benefit from dual checkpoint inhibition. Having a TP53 co-mutation without those KEAP1 or STK11 co-mutations actually predicts a better response to immunotherapy. And having a KRAS mutation alone may lead to resistance to chemotherapy. And so why has it been so tough to target KRAS? It historically was considered an undruggable target because of the lack of suitability of a binding pocket and its strong affinity to even the smallest amounts of GTP. However, in 2013, there was a breakthrough discovery of compounds tethered to cysteine of KRAS G12C. This covalent, irreversible binding to cysteine 12 residue of G12C leads to a locked KRAS in the inactive or off GDP-bound state, preventing downstream signaling and regulation. Even with this, though, 60% of KRAS-mutant non-small cell lung cancer still lacks an effective targeted therapy. This has provided the rationale for pan-KRAS concepts to bring precision therapies across a broad range of KRAS-driven cancers. And so, in summary, KRAS mutations are common and clinically significant in non-small cell lung cancer, particularly the G12X subtypes, notably G12C, as that's what we have current approved interventions for. KRAS mutations persistently activate signaling pathways that control cell proliferation and survival, mainly through mutations at codons G12, G13, and Q61. And KRAS mutations can impact treatment outcomes. Having co-mutations such as STK11 or KEAP1 may predict resistance to single-agent immunotherapy. And a better understanding of how this should predict treatment selection is something still being worked on. Thank you for your attention, and please stick with us for the other two modules. Thank you so much for joining us for the second module on breakthroughs in treating non-small cell lung cancer targeting KRAS. My name is Dr. Christine Bestvina. I'm an associate professor at the University of Chicago. We're going to focus now on what is the efficacy of current and emerging KRAS targeting therapies. We'll start with the efficacy of approved KRAS G12C targeting therapies. We'll move towards efficacy of emerging KRAS G12 targeting agents as well as combination approaches. And we'll finish with efficacy of emerging KRAS G12D targeting and pan-KRAS targeting agents. And so how do these KRAS inhibitors work? As a review of the mechanism of action, KRAS off inhibitors work by binding to a cryptic groove near the switch II region of KRAS. This forms a covalent bond with cis12, keeping KRAS in its GDP-bound inactive form. We currently have two approved KRAS targeting agents for non-small cell lung cancer in the United States and in Europe. These are sotorasib and adagrasib. Both are approved for patients with KRAS G12C mutations. Fulzarasib is currently approved in China, which is a similar KRAS G12C covalent inhibitor. These are all KRAS off inhibitors. So let's look now at the CodeBreak 200 study design. This enrolled patients with advanced or metastatic non-small cell lung cancer with KRAS G12C mutations. Patients had progressed through prior PD-1 or PD-L1 therapy, as well as platinum-based chemotherapy, either combined or sequentially. Patients had to have a performance status of 0 or 1. And importantly, patients with new or progressing untreated brain metastasis were excluded from trial, potentially different than patients that you're seeing in your practice. Patients were randomized 1-to-1 to oral sotorasib versus docetaxel. Here are the outcomes. There was an improvement in response rate with sotorasib of 28% over 13% with docetaxel. The duration of response was longer at 8.6 months versus 6.8 months. And the progression-free survival was also improved at 5.6 months versus 4.5 months. However, the trial did not meet an improvement in median overall survival, which was 10.6 months in the sotorasib arm versus 11.3 months with the docetaxel arm. Let's move now to the Crystal 12 study. Here we saw a very similar trial design with similar prior therapies, performance status of 0 or 1, and again, exclusion of active brain metastasis. Patients were randomized 2-to-1 to oral adagrasib versus docetaxel. Here we see the outcomes. There was an improvement in overall response rate at 32% versus 9% with docetaxel. Similarly, an improvement in durability with median duration of response at 8.3 months versus 5.4 months with docetaxel, and an improvement in median progression-free survival of 5.5 months versus 3.8 months with docetaxel. The overall survival data from this trial is not yet mature and has not yet been reported. We look forward to seeing these data. And lastly, we have fulzarasib. This is again available only in China, similar inclusion criteria. The primary endpoint, which is confirmed overall response rate, was 49%, with a median progression-free survival of 9.7 months. How do we move beyond those single KRAS G12C inhibitors? Well, this is where combination therapies come in, and there's a strong rationale for combining immunotherapy with KRAS G12C inhibitors. KRAS mutations suppress the anti-tumor immune response. KRAS G12C inhibitors can profoundly remodel the tumor microenvironment, and immunotherapy can reinvigorate the anti-tumor immune response, thus leading to a strong rationale to investigate the combination of KRAS inhibitors with an anti-PD-1 or anti-PD-L1 therapy. So let's look at some of our early data of KRAS inhibitors plus immunotherapy. Here we have Crystal 7. These are patients who had advanced or metastatic KRAS G12C mutant non-small cell lung cancer, no prior standard therapy for locally advanced or metastatic disease. This differentiates it from the two trials we just reviewed. Patients could have treated or stable brain metastasis. This investigated the combination of adagrasib plus pembrolizumab. Here you'll see a response rate of 59% in the PDL high group and 36% in PDL1 less than 50%. For patients who were PDL high, we saw a very impressive median progression-free survival of 27 months. So certainly exciting for the combination of adagrasib plus pembrolizumab frontline. And so with that, we're seeing this combination move forward in future randomized phase 3 trials. Here we see combinations of adagrasib plus pembrolizumab doublet or quadruplet with adagrasib plus pembrolizumab plus platinum chemotherapy. And I do think this certainly has the potential to change standard of care moving forward. Let's move now to olomorasib. Here we see a pooled analysis of 2 different trials looking at first-line olomorasib plus pembrolizumab. We see response rates of 71% in all comers and 79% in patients who are PDL high, an incredibly impressive overall response rate. 6-month PFS rates were also impressive at 83% in the PDL high group and 77% in all comers. So look forward to further development of this combination. And let's look now at some other KRAS targeting approaches. There's a lot of information here and a lot of active combinations that are undergoing investigation with combination G12C inhibitors plus chemotherapy, SHP2 inhibitors, and even HER2 targeting antibody drug conjugates. Stay tuned to this space because I do think there's a lot of exciting data to come. So let's move now towards novel KRAS G12C targeting therapies in non-small cell lung cancer. Why are these important? Well, there's been no significant improvement in overall survival when used in the second line compared to docetaxel. Additionally, acquired resistance, or resistance through adaptive mechanisms or histologic transformation, remains an issue. How else can KRAS be targeted? Here's where KRAS-on inhibitors come into play. These form a tri-complex with cytoplasmic proteins, and this GTP-bound active state prevents further downstream signaling. We also have rationale for non-G12C as well as pan-KRAS targeting therapies. So despite the success of KRAS G12C inhibitors, 60% of KRAS-mutant non-small cell lung cancer still lacks an effective targeted therapy. De novo second site non-G12C mutations, such as G12D or V, can induce acquired drug resistance. And pan-KRAS concepts aim to bring precision therapy to many patients, not just those who have KRAS G12C mutated. This is an extensive unmet medical need and extremely important to allow access to targeted therapies for all of our patients with non-small cell lung cancer. Let's look now at some of the other emerging KRAS targeting therapies. There's multiple different mechanisms by which we're also trying to target KRAS. There are new and emerging KRAS-off inhibitors that still target KRAS G12C or G12D. We have KRAS on-off inhibitors, including those that are targeting G12D. We have emerging KRAS on inhibitors focusing on G12D, C, as well as other targets, and even PROTACs. These emerging agents are addressing active KRAS, non-G12C mutations, as well as using alternative mechanisms of action to try to really target KRAS through a variety of mechanisms. What is some of the emerging data that we're seeing for KRAS G12D? Let's take a look at zoldonrasib. Here we see an overall response rate of 61% with a disease control rate of 89%. Very impressive data, and I look forward to more from this compound. How about emerging pan-KRAS targeted therapies? Here we have daraxonrasib with a response rate of 38%, a duration of response of 15 months, and a median PFS of 9.8 months. Again, extremely exciting data in the pan-KRAS targeting therapy space, where currently there are no other approved targeting agents. And so, in summary, KRAS G12C inhibitors show efficacy in non-small cell lung cancer, but we have yet to see an improvement in overall survival in a randomized trial. KRAS mutations drive immune evasion, supporting combinations with PD-1 or PD-L1 blockade. KRAS inhibitors in combination with immunotherapy show promise, and there are multiple trials ongoing in the frontline space. Next generation agents will target both non-G12C KRAS as well as novel mechanisms such as PROTACs. And emerging KRAS G12C, D, and pan-KRAS inhibitors show early efficacy, and I look forward to exciting data emerging in this space. Thanks so much for your attention, and hang with us for Module 3. Thank you so much for joining us for this third module on breakthroughs in treating non-small cell lung cancer targeting RAS. My name is Dr. Christine Bestvina. I'm an associate professor at the University of Chicago and a thoracic medical oncologist. What are the safety profiles of current and emerging KRAS targeting therapies in non-small cell lung cancer? We're going to look first at the safety and tolerability of approved KRAS G12C therapies, including the most common any grade and grade 3 treatment-related adverse events, as well as how that might impact dosing. We'll look at mitigation and management of adverse events, including considerations of prior and combined therapies. And we'll finish by talking about the safety and tolerability of emerging KRAS agents, including emerging G12C inhibitors, G12D, and pan-KRAS targeting agents. And so here we have the common adverse events that are reported with KRAS G12C inhibitors that are currently commercially available. You'll see in gray those that happen with sotorasib, in orange those that happen with adagrasib, and in blue those that happen with fulzarasib. The most common adverse events that we see with sotorasib and adagrasib include diarrhea, nausea, and vomiting, though these GI toxicities occur at a higher rate with adagrasib. AST, ALT increase occurs across all three drugs, as high as 30%. Also importantly, we can see some anemia, an increase in blood creatinine, increase in fatigue, and asthenia. When focusing on grade 3 or higher treatment-related adverse events, particularly those that have at least a 5% incidence, we see this side effect profile narrow down to really AST and ALT increase, hepatic function abnormalities and GGT increase, diarrhea, anemia, and lymphocyte count decrease. So really, in general, we're talking about GI toxicities as well as blood count abnormalities. But potentially, most importantly, these do not stop many patients from continuing to receive these efficacious therapies. Many patients may need dose interruptions or dose reductions to help manage these adverse events. However, very few patients, as few as 7 to 8%, actually discontinue any of these drugs due to treatment-related adverse events. And so if a patient in your clinic is really suffering from, let's say, diarrhea, or if they experience AST or ALT increase of grade 2 or 3, know that it's okay to dose interrupt and even potentially dose reduce, but still be able to safely re-challenge the patient after that so that they can continue to have access to these important and efficacious drugs. Let's look now at safety considerations for patients who are starting sotorasib after prior immunotherapy. There's a higher rate of severe adverse events, particularly hepatotoxicity, for patients who received sotorasib directly after immunotherapy. For patients who had prior immunotherapy, they have higher grade 3 or 4 treatment-related adverse events with sotorasib than those patients who had prior chemotherapy as opposed to immunotherapy right before. Also importantly, timing does matter here. For patients who had immunotherapy within 3 months of starting sotorasib, those rates of hepatotoxicity are as high as 33%, while if the period was at least 3 months between the immunotherapy and the sotorasib, that rate decreased down to 14%. And so, if at all possible, try to avoid sotorasib until 4 to 6 weeks after immunotherapy. Though importantly, we may not always be able to do this in clinical practice. Sometimes there is an urgency to get patients started. And so if that's the case, just be clear about making sure you're monitoring LFTs at a regular interval and be aware that you may need to dose interrupt. Concomitant medications are something that are particularly important to be aware of with both sotorasib and adagrasib. Proton pump inhibitors and H2 receptor antagonists should be avoided, as well as strong both inducers and inhibitors of CYP3A4. And so this is a place where having a pharmacist who's involved in your team who can really look through the patient's medication list can be really important. It's also important to have a recent and accurate medical reconciliation of the patient's medications that they're taking at home. Let's look now towards some mitigation and management strategies of serious adverse events. We'll focus on 4: hepatotoxicity, QTc interval prolongation, GI toxicity, and ILD. Hepatotoxicity is something that can occur with both sotorasib and adagrasib. And again, just important to monitor hepatic function both prior to starting treatment as well as on treatment. For QTC prolongation, this can occur generally with adagrasib. Having a baseline EKG is very important for these patients, and EKG and electrolytes should be closely monitored in these patients, given the potential risk for QTC interval prolongation. Moving now towards GI toxicity, which is more severe with adagrasib, patients may need significant supportive care to get them through this GI toxicity and may also need dose interruption or even dose reduction to handle the GI toxicity. There is a theoretical risk of ILD with both sotorasib and adagrasib, and patients should be monitored for new or worsening pulmonary symptoms throughout their treatment. This is one that I take very seriously in my clinical practice. If a patient reports new cough or shortness of breath, I have a very low threshold to get a CT scan to assess for ILD. Let's look now at certain combination approaches and how that may affect the rate of adverse events. Here we see sotorasib plus chemotherapy, and we saw predominantly that the grade 3 or higher treatment-related adverse events were hematologic in nature, which makes sense given the chemotherapy component. We look forward to new data for this combination chemotherapy plus sotorasib from the CodeBreak 202 trial, looking at frontline PDL negative patients with a combination of sotorasib plus chemotherapy versus chemo plus pembrolizumab. I think importantly, what we do know is that sotorasib cannot be safely combined with immunotherapy, and that combination is no longer under development. Next, let's move towards pembrolizumab combinations. So here we see adagrasib plus pembrolizumab as well as olomorasib plus pembrolizumab. And across both agents, the most common grade 3 or higher treatment-related adverse event was AST and ALT increase. Again, these can often be monitored with these can often be intervened upon with dose interruption or dose reduction, or in severe cases, potentially corticosteroids. What do we know about some of the new and emerging KRAS G12C inhibitors? So as far as the new off inhibitors, such as divarasib or olomorasib, we see pretty consistent with known G12C inhibitors. So AST, ALT increase, diarrhea, fatigue, and nausea. RAS-on inhibitors, we're thus far seeing some grade 3 QTC prolongation, similar to adagrasib. Again, speaking to the importance of monitoring with EKGs to make sure that that QTC interval is not being prolonged. As we get more use with these new agents, I think we'll have a better idea of the full safety profile. Let's look now at the safety of emerging G12D KRAS inhibitors. And here you'll see that there are multiple G12D KRAS inhibitors being developed across multiple tumor types, speaking to the prevalence of KRAS mutations across multiple solid tumors. Importantly, there isn't really a clear safety profile that's emerging. We're seeing anything from hypercholesterolemia to AST, ALT increase to blood count abnormalities. And so we're really going to need to gain more experience with these KRAS G12D inhibitors to have a better understanding of the full safety profile. And lastly, we have daraxonrasib, an emerging pan-KRAS targeting therapy. Here again, we see rash, vomiting, anemia, diarrhea. As we get more experience with this emerging pan-KRAS inhibitor, I think we'll have a better sense of what that safety profile looks like. And so in summary, KRAS G12C inhibitors can frequently cause hepatic and GI toxicities. Recent immunotherapy increases the risk of hepatotoxicity with sotorasib. Careful adverse event monitoring and mitigation is essential for optimal outcomes. KRAS inhibitors have been used in combination with both immunotherapy and chemotherapy and are generally well tolerated, with the exception of sotorasib plus immunotherapy. And emerging KRAS agents show similar toxicity. More mature safety data is needed. Thank you so much for joining us in this series on KRAS inhibition. and I look forward to seeing more new and exciting data emerge in the next coming months and years as we continue to work for the progress of our patients.